All right, welcome everyone. Thank you for taking the time to join us for today's webinar on the long-term outcomes of NEC. We are recording, and we do hope to have the recording of this webinar available on necsociety.org within the next week or so. All of our attendees are on mute, but we'd love to hear from you. So if you have questions, you can use the Q&A tool. If you have comments or just remarks you'd like to share, there is a chat box. We'll be monitoring that throughout the webinar, but some questions will be held to the end so we can have more of a discussion around them. We're really thrilled to share that this webinar has attracted people from all over the world. Our fall webinar series has had about 600 registrants from across, I would say, about 50 different countries. So we're really so thrilled and grateful to have an international, very diverse community joining us and believing in our vision of a world without NEC. So thank you for being here. And before we get started, I do want to thank our generous supporters who make this work possible, including the Patient-Centered Outcomes Research Institute, the Chan Zuckerberg Initiative, and the hundreds of individuals, patient families, and other groups that support our work and believe in our vision of building a world without this disease. I do want to share that today's webinar is dedicated to Lakevia and Lindsay. They both attended the NEC Symposium at the University of Michigan last year. And while they were with us at this conference, they were able to articulate and really help us recognize how little is known about the long-term effects of this disease and how few resources are available to survivors. And so they've really been able to help us push this work and these efforts forward. So we're really thankful to both of them, to the many other NEC survivor families that have really encouraged us to do more here. In just a few minutes, you will hear from Lindsay, so you can look forward to that. And I'm going to advance to the next slide. So some of you may have joined us previously on September 30th for our webinar on cardiac NEC. That recording is now available on our website, and in a moment I'll share the link in our chat box where you can see the recording and the slides from the cardiac NEC webinar. We'll have another webinar coming up on November 18th that will focus on the NEST trial, so we hope you can join us then. And speaking of the long-term outcomes of NEC, we do have a study going on right now where we're looking to understand how this disease affects individuals and families decades after their original diagnosis. And we're looking at quality of life and social, emotional, and just all the wide range of complications and effects that this disease has during childhood, teenage years, and into adulthood. And again, this survey and this research project was really has been led by people like Lakevia, Lindsay, and other survivors who helped us develop the questions and figure out how to best ask these questions and so forth. So we're really grateful to them. We've had about 230 families and survivors respond to this survey so far. We'd love to have more, especially diverse groups responding and families responding. So if you are able to help us circulate this link and to families who may be able to participate, we'd love that. It's available on our website. We will be closing the survey in the next week or so, so we really hope that you can help us circulate that before we close it. We're really excited to share that we are hosting our first virtual charity run on December 12th and 13th. The link is down there in the corner. We will be sharing this on our website and social media, so we hope that you might consider joining us for that. And then finally, here are your speakers for today. So for those of you who I haven't had the pleasure of meeting, I'm Jen. I'm the founder and the director of the NEC Society. I lost my son Micah to the complications of the disease when he was about 11 months old. You'll hear from Lindsay, who I mentioned is a NEC survivor herself, and she helps us to lead the NEC Society. You'll hear from Susan, who's a neonatologist and a perinatal epidemiologist at Stanford. She'll be talking about the neurodevelopmental outcomes of NEC. Ira is joining us. She's a neonatologist at Emory, and she's going to be talking about short bowel syndrome, impacts on the family, and also some neurodevelopmental outcomes. Jonathan is our strategic advisor. He's going to be serving as our MC for the day. And then Ravi also helps to lead the NEC Society, and he's a neonatologist at Emory who will help facilitate our discussion and our Q&A. So that's who you'll hear from today. And for anyone that's new to the NEC Society, welcome. We're really excited to have you. We are a 501c3 nonprofit organization that brings together patient families who have been affected by the disease, clinicians, researchers, and other diverse stakeholders who are committed to building a world without this devastating disease and improving outcomes for these most vulnerable infants. Our work really focuses on advocacy, research, and education. And if you're not already, I hope you'll consider following us on social media. We're on Twitter, Facebook, LinkedIn, YouTube, and Instagram. And you can also check us out on our website. We have a blog and so forth. So there's that. And I'm going to just do a quick disclosure before I hand it over to Lindsay. The NEC Society is not providing any medical advice. We are not providing any medical advice during this webinar, and all of our speakers' views and perspectives are independent from the NEC Society. So thank you all so much again for joining us, and I'm going to hand it over to Lindsay.
Hello, my name is Lindsay Green, and I am a performer, storyteller, and student. I also work with the NEC Society on social media, research, and patient-family advocacy. There we go. A full-term baby, I was born on August 13th, 1997, and shortly thereafter, I was diagnosed with NEC. 3 months and 2 surgeries later, I finally came home, but that was not the end. Now, before I continue, I have a question. How many of you have heard someone whose body has been impacted by NEC speak before? I'm sure that for a number of you, this might be your first time. So to really be able to address our needs, you have to engage with and understand us. We are really a very colorful and multifaceted community. And what you're about to hear is only one person's story, and one story is not enough. And I'm not gonna lie, as a young adult who is striving for normalcy, some of what I am about to disclose is kind of embarrassing. So I appreciate your kindness, patience, and open-mindedness. I had a relatively normal childhood. I was never able to eat more than small amounts of food in one sitting. Sometimes the tiniest bit would land like a boulder in my stomach. And if I tried to finish my food, I would feel ill and often vomit. When I was a kid, dairy started to become difficult to digest. And a few years later, that expanded to foods that were very high in fat, such as deep fried foods. And I've struggled with being underweight all my life, so this reaction to food did not really help. I was always really bad at sports. My gross motor skills were so poor that my gym teacher asked my mom if I was really left-handed. My parents had read that by the age of 7, the disparity between my academic performance and that of my peers would become evident. And my mom was a school teacher, so she worked constantly with me to make sure I could keep up. And by the time that I was 7, I was actually a level ahead in most subjects, and now I attend Cambridge. It was important that my parents did not resign to the limitations that were prescribed for me. There was still some hope. And then there was my scar. Some mornings when I was very small, I would curl up into a ball on my bed and say that my scar hurt. It felt like a blade was sawing through me. But these episodes were infrequent and they were pretty brief, so we didn't think much of them. Then one day, when I was 16, I started my school day with the same pain I'd felt years ago. But it didn't go away. Instead, it became increasingly worse, as if I was being carved into slices of meat. The staff at the ER believed I may have been on my period, or it might have been a urinary infection, and they couldn't find the root of a cause. And that was the first time in my life when I was genuinely convinced that I was going to die. Then a nurse mentioned that she had heard something somewhere about long-term complications of NEC, and it turned out that's what it was. By the time that I was transferred to a larger hospital, I was shaking violently and drifting in and out of consciousness. I was given a blanket, even though I was not cold. My blood pressure was very low. I was vomiting like a geyser, and my stomach was hard and swollen. A CAT scan revealed that I had scar tissue and adhesions. My digestive system was frozen in place. I was told to eat better and was sent home with an enema. And for the next few days, I was still in a lot of pain, and I was very weak, and it was very difficult to walk. And after that moment, the amount of food that I could tolerate at once actually grew smaller. And this episode repeated itself at least once a year. And in between those hospital visits, I had pretty regular bouts of pain at various levels of severity. And each time it was the same routine: scar tissue, inflamed intestines, probably some kind of obstruction. They'd prepare for an emergency operation and then change their minds at the last minute. I'd be told, no, that has nothing to do with necrotizing enterocolitis. That only pertains to babies. They never knew what was wrong with me, but they always knew what wasn't. They'd say, honey, I don't know what to say. You've really got to start taking better care of yourself. I don't know, watch your diet, lay off the burgers, okay? I'm a vegetarian, but that's neither here nor there. I needed to know what was going on and what to expect for the future, and how to take care of a post-NEC body. One GI told me I'd need a colonoscopy, but never reconnected with me after I had an MRI. And another GI was honest with me and said there was really nothing that could be done, so there was no point in seeing her. There simply was not enough research that had been done about NEC's long-term outcomes. Most recently, I've become increasingly nervous. Sometimes when I use the restroom, I'm seized with nerves and I'm just frozen and crying. Some days I feel like I've been dropped into an anthill. I fall, I black out a lot. 2 months ago, I was walking down a hall and suddenly I heard myself hyperventilating, and I heard this rhythmic bump, bump, bump against this wall. And when I opened up my eyes, I was face to face with the floor, and random parts of my body were just throbbing as if I had just been flinging myself repeatedly into the corner of a wall. And I just started crying because I didn't know what had happened. I didn't know what my body had just done. And I didn't know what was wrong with me. And really, that's the overall sentiment about my condition. What's wrong with me? If I discovered long-term complications when I was 16, how much worse will things get? And who will help me navigate this? At the NEC Symposium in 2019, I co-facilitated a work group focused on empowering patient families with NEC survivors. And it was wonderful to have a space where patients and parents could actually feel heard and validated by professionals. And I remember there was this one nurse who told me that she had never heard of NEC's long-term outcomes before. She said that she thought that they sewed up the baby, they sent the baby home, and that was the end. And it made me realize just how important it is that we reevaluate how we are holding these conversations about NEC. From that session was born the Long-Term Outcomes Survey. Co-led by Heather Denchik, a mother of a NEC survivor, and me, the project was developed over the following months. And we were guided by questions we wished we had been asked, by the needs we wished could be addressed, and the information we wished we could acquire. Our hope is that the data we collect can help us paint a more accurate portrait of what it means to be a NEC survivor, and hopefully that data can help other people help us. And now, I challenge you to consider this request. Please do not sew us back up and send us home, only to forget about us. Please do not save our lives, only to forget about our quality of life. If you've saved a life, and then that life is ruined due to a lack of access to credibility, to care, to knowledge, what was it for? What is the next step? Or as we like to say in improv, yes, and. You are not just handling a baby, you are handling a future. I challenge you to imagine yourself in my position. Imagine not being able to access the help you need to improve your quality of life. Imagine yourself drifting in and out of consciousness, vomiting, shaking uncontrollably with unbearable pain, and having to convince your nurse or your doctor that the condition you have exists. I challenge you to include all of us. Reach out to NEC survivors and our families. Gather our stories. Ask us what we need. It is a big ask to fully articulate and address next long-term outcomes, but we can start by building a world in which we are believed, in which we have access to providers who know what necrotizing enterocolitis is, and in which we are properly recognized not as graduates of the NEC community, but as active members. Redefine what it means to be done. Please do not tell us, not now, this is not the time. When I'm in the emergency room, my body does not hear that. Now, I do hope there will be a day when I won't have to fear for my future. And I hope there will be a day when I can hear a doctor say, yes, I believe you. Yes, I can and will help you. Believe it or not, this space determines whether or not progress will be made towards that. I cannot do this by myself. I'm an artist. This is going to take many of us. Now, I am not the spokesperson for every NEC survivor, but this I can confidently say on behalf of all of us. Our quality of life hinges on someone's ability to say, yes, I will help you. Thank you.
Lindsay, thank you so much. Phenomenal speaker, and what a powerful story, grounding us exactly where we want to be and thinking about the issues we want to be thinking about. So thank you very much for sharing that with us.
Thank you.
I'm going to turn the floor over to Susan from Stanford, who's going to start walking us through how to think about some of this and how we can keep the conversation moving forward. Susan, the floor is yours.
Thank you very much. First, just thank you to the NEC Society for the honor of the invitation. But really, I want to thank you, Lindsay, for sharing that incredibly powerful story. I think probably there are not many dry eyes in the audience at this point. If there have ever been a few minutes that I've listened to that has truly driven home the importance of truly long-term follow-through, it is those minutes. And yes, we all have a responsibility, and I think we feel it deeply for people like you, for your family, and for the future. So in terms of my presentation overview, I'm really going to be focusing on what unfortunately are mostly short-term neurodevelopmental outcomes in this realm, and the significant challenges to interpretation. There are few school-age outcomes, but we will talk about those. I will also be I'll be touching on what may explain the association between NEC and adverse neurodevelopmental outcomes, and as Lindsay so eloquently described, the need to shift the focus to outcomes that really matter to NEC survivors and their families. As everyone in this audience knows, NEC remains a potentially devastating and unfortunately not uncommon complication of prematurity. It is a variable and varied outcome with a rate that ranges between about 3 and 9%, depending on site, depending on patient population, etc. I'm just showing you a couple of studies here. Here, the Vaughan, a recent study by Hahn et al. In the Vermont-Oxford network showed overall between 2006 and 2017 a NEC rate of about 7.5%. But if you look here in the gray, encouragingly, the rate of medical NEC, or NEC that is managed medically, came down to about 3% by 2017, and surgical NEC to about 3.1%. In the CPQCC, you can see here as well that the rate of all necrotizing enterocolitis in dark circles here also decreased between birth years 2018 and 17. This was concurrent with an increase in human milk use at discharge that went from about 52% to 61% during that same period. But I think very importantly was the fact that this analysis by Goldstein and colleagues uncovered some substantial racial and ethnic disparities that showed that this decrease in NEC rate really was benefiting white infants more than non-white infants. So we have a lot of work to do. So similarly to the wide variation in incidence is the variation in reported mortality associated with NEC. And shown here based on recent publications, 20 to 50% or more. In a recent excellent systematic review by Jones and Nigel Hall, about 23.5% of those with necrotizing enterocolitis overall died after necrotizing enterocolitis, with about 34.5% among neonates that underwent surgery for NEC. But they also did a very nice job of showing the range in these groups. So among those with all NEC with a birth weight of less than 1,500 grams, about 30% mortality rate. But in the higher risk category, infants less than 1,000 grams birth weight who needed surgery for NEC, as you can see here, about 51%, but with a wide 95% confidence interval. So this brings us to the incredibly important need to understand the outcomes of NEC survivors far beyond the exit doors of the NICU. Although much of this presentation is going to focus on early neurodevelopmental outcomes, as I mentioned, it really must be acknowledged that some of the truly critical outcomes have not even been explored, as Lindsay very eloquently noted, and why this group, the NEC Society, and the work that you are doing and that you have done is so critically important. So because this is a broad group, I wanted to first start by kind of highlighting how neurodevelopmental outcome is measured in preterm infants in general. So first and foremost, follow-up of preterm cohorts generally finishes at 18 to 3 years only for the vast majority of trials and prospective cohorts, which is obviously not very long. Gross motor function is generally by a neurologic exam, and generally the outcome of cerebral palsy is the main neurologic or motor outcome that is identified, and cognitive development and assessment is by generally the Bayley scales of infant and toddler development, although as you might know, there have been several versions, and that leads to some complications in understanding the various studies. There are also usually some hearing and vision questions or assessments. Neurodevelopmental impairment is generally considered an outcome for many studies, but it is a composite outcome. It combines criteria and cut points from all of those domains and sometimes other domains, and it is generally categorized by severity. But again, the definitions and the cut points really are different among studies. So this brings us to the many challenges to interpretation of this so-called neurodevelopmental impairment. So first, the relative prevalence of each of those components in that composite outcome is very different. And each of these components may be responsive to interventions in very different ways. So whenever we're thinking about a trial, that really needs to be considered. Also, as I mentioned briefly, there have been changes in instruments over time, and it can be very difficult to understand developmental delay as you're trying to combine different studies from different time points. Neurodevelopmental impairment as a definition itself is not consistent across studies, and this was very well described by the Canada Neonatal Follow-Up Network, showing a fourfold difference in severe neurodevelopmental rates across studies, and even within their own site. And then really the most important thing, perhaps among all of these and others, is the general absence of a family and functional perspective and the general absence of a life course context to neurodevelopmental follow-up. add to these general neurodevelopmental challenges the specific challenges that are intrinsic to defining NEC and to diagnosing NEC, which have been very elegantly laid out by Ravi Patel and by Jay Kim and their co-authors, including Jen Canvasser, in the NEC Society research, pediatric research supplement. And we really have a number of challenges that we need to deal with as we consider neurodevelopmental outcome data. So with the increasing recognition and the need to understand post-discharge outcomes, there were a number of multiple small case series and then single site cohort studies that started in the late 70s and early 80s. Those were followed by larger studies from multi-center networks, including from the Neonatal Research Network of the NICHD and more recently from Vaughan. And overall, what we learned from these studies is that infants who had a history of NEC appeared to be at higher risk for adverse neurologic and developmental outcomes than those without NEC. And again, these were generally short-term outcomes. There have been a number of systematic reviews, including earlier systematic reviews by Sven Schultzke and another by Claire Rees, but a recent systematic review attempted to pool all of these multiple studies by Andrea Matai, and I'm going to go through a couple of slides about that systematic review here. First, just to sort of drive the point home, these are the 31 studies that were included in the quantitative synthesis of that systematic review. And you can see here what I was referring to in terms of quite a bit of variation. Variation in study period in terms of birth year, in even age at follow-up month, at months at follow-up. The number of patients that were included is quite different among these. And even in these two very large studies, the follow-up rates were quite different, with greater than 80% follow-up in the network study and about 50% in the recent Vaughan study, just based on the kinds of cohorts and studies that were going on at that time. So this is a forest plot of neurodevelopmental impairment, kind of combining all of these studies that were done into kind of one package, and that's what this forest plot is showing you. And you can see all of these studies are kind of showing mostly all to the right, which is showing a higher risk among NEC patients for this composite outcome of neurodevelopmental impairment. So among all of these children combined, it was about a 40% risk of neurodevelopmental impairment among those with a history of NEC compared to 29% without. And you can see here about a 1.6 fold increase in risk ratio. Pulling out just the information about cerebral palsy, again, the data looking to the right of this line that basically is equivalency, and again, about a 1.8-fold increase in risk for cerebral palsy, about 17% versus 7%, and this was highly significant. And then finally, looking at medical NEC versus surgical NEC, again, this is a little bit more, a little bit less, clear, but about a 1.6-fold increase in risk among those children who had a history of surgical NEC compared with those with medical NEC, 43% versus 27% for the outcome of neurodevelopmental impairment. And again, just to reiterate, these are very variable studies. The outcome definition varies, and as Lindsay said, each individual NEC story is very different, just as each individual NEC survivor is different. So these are just compiled data. I will just point out to you also that there was a recent, it's still actually in press, a large study from the Canadian Neonatal Network and Follow-Up Network, and that was by Dr. Zazaya, as well as Ann Sinnis, and also part of this was Prakash Shah. And they did basically a very large retrospective study of children who were in the NICU in 2010 and 2011. And what they found among survivors was also an increased risk or an increased odds ratio of neurodevelopmental impairment among all NEC survivors, as well as lower motor and cognitive Bayley scores and lower head circumference. So what about necrotizing enterocolitis with respect to longer term outcomes? Well, sadly, as I mentioned before, really very little data exists about school age outcomes, but I'm going to share with you some of the high level data that does exist just to illustrate what is out there. Probably most well known is the study by Katie Pike and the Oracle investigators. Oracle was a large multi-center trial in the UK of antibiotics to mothers who had had preterm rupture of membranes or spontaneous preterm labor. There was a 7-year follow-up with parental questionnaires in that study, including the Health Utilities Index, and also linkage to UK national standardized educational tests. And what was seen when they pulled out those patients with NEC, and it was really any NEC, was that there were increased rates both of overall health-related quality of life and functional difficulties and other concerns. So there was about a 1.5-fold increase in adjusted odds ratio of any functional impairment, 56% with NEC compared with 40%. There was also a highly significant increase in any bowel problem in NEC compared with no NEC patients. And for parent-reported attention deficit hyperactivity disorder, there was also about a 2-fold increase in odds among those with NEC compared to those without NEC. The next study that we can discuss is that of the German Neonatal Network, and this is a neonatal network that is a multi-center network, and this was from data from birth years 2009 to 2014. A subgroup of this entire group was asked to follow up at 5 to 6 years, and there was about a 55% follow-up rate for that group. And of those that returned, they had a neurologic exam for cerebral palsy, as well as an IQ test called the WIPC-3 at that point, and also some growth parameters. The primary focus of this study was surgical NEC, compared with no NEC and no SIP, and looking at the entire group, there was about a 3-fold increase in risk among the surgical NEC group compared with the no NEC group to have an IQ of less than 85. But they also underwent a matched control type of study. And what they found there was a decrease or a decrease in IQ among those with NEC, total IQ, as well as verbal IQ. And then, as you can also see here, a decrease in head circumference and length in compared with those that did not have either SIP or NEC. There's also a study out of Denmark, and this is a nationwide historic cohort study. This is by Matthias Hansen. And this was basically including all children they looked at who were born 2002 to 2011. And they looked at this by the registry, by ICD-10 codes, and then basically sent parental questionnaires, which were really the strengths and difficulties questionnaire and other parent questionnaires to this group. So the primary outcome was really on the SDQ and the total difficulty score. But I just want to highlight the fact that this is quite a range. So this was capturing children who at the time of this questionnaire were anywhere between about 5.5 years to about 15 years of age. Again, the response rate was relatively low, but for a survey, it was about right. And what they found was that among NEC versus no NEC parent respondents, there were higher rates of this total difficulty score being higher in this questionnaire, as well as moderate to severe cerebral palsy and small head circumference. Although this didn't reach statistical significance, there were differences as you see here. So really, what explains this association between NEC and adverse neurodevelopmental outcomes? Well, I think first it's interesting to look at the list of factors that have been purported to be associated with developmental outcomes in preterm infants in general, and those that are associated with complications with NEC and the overlap. So this is by no means a complete picture, but sepsis and infection is certainly among those. Surgery, abnormal neuroimaging findings, which we'll get into a bit later, bronchopulmonary dysplasia, and of course, increased length of stay, nutritional deficits, and NICU or clinical site. And you can see a lot of inflammatory issues that are related with those factors that are in common. So this, I first will, apologize for this really probably highly simplified sketch of what are really a myriad connections and potential connections between factors and outcomes. As Joseph Volpe and others have really certainly more eloquently described than I will, the preterm infant is in a precarious window. They are highly vulnerable for white matter injury and other brain developmental injury through a number of different mechanisms. So as we are all aware, necrotizing enterocolitis is a highly systemically inflammatory event. And that can certainly contribute directly and indirectly to this cascade toward brain injury. With systemic hypoperfusion, for instance, and hypotension, there can be cerebral hypoperfusion through a mechanism that's linked to impaired cerebral autoregulation. Also, microglia activation has been implicated in this cascade, and microglia are sort of the macrophages of the central nervous system. They are the immune defense, simply put, of the central nervous system. And there are a number of things that can activate them to release cytokines and to release a reactive oxygen species. Among those, ischemia reperfusion injury has certainly been implicated in that cascade, and inflammation or infection can lead to activation of microglia, and that can therefore happen in the presence or absence of infection. So there are a lot of issues that lead to this cascade, and I will also highlight the fact that this cascade and this kind of injury may have direct neuronal impact as well. So not just the white matter, but the neurons can also be impacted. And interestingly, there has been some very interesting neuroimaging evidence linking NEC and adverse neuroimaging findings. This is also from the Andrea Matai systematic review. And you can see here that in this systematic review results that NEC was associated with periventricular leukomalacia, almost a twofold increase in risk by cranial ultrasound. Others have done MRI studies, and this is among infants who were born very preterm with conventional MRI showing an increase in moderate or severe white matter injury, almost a 7-fold increase in the odds for that finding. And those findings were also associated with lower Bailey scores and increased rate of cerebral palsy. There is also other data that links this NEC and inflammation with brain injury, including a study by Chow that showed on advanced MRI there's proven there is an associated widespread brain abnormality seen. In the E' study as well, this was identified, NEC was identified as a factor for diffuse white matter abnormality on more advanced MRI imaging. And also in 2 studies, both at 2 years of age and at 9 years of age, NEC and sepsis or NEC was associated with white matter abnormalities, which was also linked to cognitive impairment at those 2 age ranges. And this really demonstrated or drove home the fact that white matter abnormalities may in fact be the link to those findings. I also just want to highlight, this is an exploratory study that was done actually at Stanford by Sarah Dubner and by Heidi Feldman and their group. And this was on advanced neuroimaging looking at very specific white matter microstructural abnormalities. And this was in a group of preterm infants compared to a group of term infants at 6 years of age with this imaging. And what they found was that there was significant white matter microstructural abnormalities in multiple areas of the corpus callosum, which is a very rich fiber tract that has been implicated in a range of cognitive functions. And really interestingly, the better white matter indices in this area, the occipital region, was linked to better performance in IQ, reading, and executive function. And when looking at just the children who had NEC or BPD or sepsis, they really had the worst white matter indices in this area. So again, it's exploratory, but it helps us to try to understand better what these links are. There are also a number of very interesting possibilities that we can gain also from the last few slides in our clinical observations, that there might actually be multiple hits going on, including a cumulative effect with infection potentially, as well as the potential surgical implications that surgery itself has been linked to adverse outcomes in some cases. However, having said that, with the next webinar you'll be having with Dr. Blakely, we certainly want to be cautious not to say that surgery in and of itself is something to avoid when indicated. And so with all of that, of course, you know, we need to and we want to, and as Jen has noted so urgently, we need to move toward prevention and a world without NEC. But in the meantime, we also need to better understand the outcomes that really matter. And these three women, Maureen Hack, Betty Vore, and Sarush Segal, are perhaps some of the strongest influences in my professional life. And they have highlighted in so many ways how the most important voices that we can listen to are families and the children, adolescents, and adults themselves who are survivors. And this is definitely applicable to the survivors of NEC. I just want to highlight again that these two-year outcomes are extraordinarily limited and very incomplete windows to the future. And really, we need to be listening to those survivors of NEC, telling us the stories like Lindsay has of the functional, physical, and psychological health issues that they are undergoing, and really pursue those. Another story that Lindsay has told before is the difficulty in transitioning to really understanding of her care team, and having even difficulty finding physicians who can take proper care of her and her specific needs. So for that reason, I am thrilled that you are pursuing this study, and I too will be spreading the word. And thank you to the NEC Society for this important research, and thank you for the opportunity to present to you today. Thank you.
Susan, thank you so much. Absolutely, just for sharing your expertise and brilliance and such rich content. Thank you very much. So on that theme and continuing the theme of sharing your brilliance and expertise, I'm going to hand the floor over to Ira from Emory. Ira, I think whenever you're ready, you can turn your video back on and share your screen. Ira, it looks like you're still on mute. If you want to take yourself off mute and turn your video back on, then you can start your screen share.
Okay, I think everything is connected now. I wanted to thank each of you for joining this very important webinar today, and for the NEC Society for putting together this great meeting of all the important stakeholders, not only providers, but also parents and patients. And I think it will help us to do exactly what we've been discussing today, is understanding outcomes better and the impact on the family. And so my portion of the presentation today will focus on neurodevelopmental outcome and surgical short bowel syndrome and its impact on the family. I have no conflicts of interest or disclosures. Thanks to Susan for presenting a great foundation for much of what we'll be building upon in this segment of the talk, because the subset of patients with surgical short bowel syndrome is just a subgroup of the patients that she's very nicely described in terms of what we expect and what we see from these patients. And so during our presentation overview today, I'll define surgical short bowel syndrome and the definitions that we have, or the best definitions that we have, as well as identify some of the risk factors that we know affect these outcomes. And then I'll talk a little bit about my journey with short bowel syndrome and how I became more interested in this, looking at two local studies going on, or that I've done at my center with our intestinal rehab team and also our NICU population, and then review a study that's being submitted for publication from the NRN of a larger subgroup of patients. And again, I think it's important for us to recognize and acknowledge that there are shifts in neonatal care, and also in the role of our intestinal rehab teams at the various centers, and the importance of these teams in meeting the unmet developmental needs of this population. And finally, acknowledging the impact on the families. So when I think of developmental outcome, this is really a paradigm that I've put together that I think on a high level explains the issues at hand. I think when it comes to prematurity and neurodevelopmental outcome, your gestational age and birth weight form the foundation of what's really your baseline risk. And then you have a prolonged neonatal hospital stay, multiple complications. And even though this is not a complete list, I've included some of the important things. These further add to your baseline risk of gestational age and birth weight on neurodevelopmental outcome, including CNS injury, chronic lung disease, NEC, as Susan has discussed, and then that subgroup of patients who develop surgical short bowel syndrome at the pinnacle of this paradigm. In terms of definitions, there's really not a defined definition for NEC. Not for NEC, I'm sorry, for surgical short bowel syndrome. Is more of a functional definition, such that we have a loss of bowel length or functional integrity, such that the GI tract is unable to absorb the appropriate fluids and nutrition needed for growth and development. The causes are multifactorial, but in a pediatric population, NEC is the most common cause. And we know from previous studies that have been reported that surgical NEC patients are at greatest risk for neurodevelopmental outcomes. Therefore, when we talk about surgical short bowel syndrome, this is really the most extreme manifestation of that subgroup of patients. And as one might expect, these patients have the greatest risk for adverse neurodevelopmental outcomes. It occurs in approximately 0.7% of children less than 1,000 grams and approximately 1% of children less than 1,000 grams. And as I said, no uniform definition, but some of the variables that have been considered are the amount of remaining bowel length, which is difficult because everybody measures it differently. Pre-mortem versus post-mortem specimens will give you different measurements. How much bowel remaining for survival that's needed, that number has changed over time. The presence or absence of an ileocecal valve. A novel concept is one that estimates a percentage of the remaining bowel length based on the patient's weight and body length. and then again, the absorptive capacity needed to support nutrition. This graphic here shows you the GI tract from top to bottom, and you can see that the GI system is a very active organ system. At each segment of the GI tract, there are distinct and unique functions that occur in each of these segments, and that's part of the reason why with surgical short bowel syndrome is not a set list of issues that you have to deal with, because it's all relative to which portion of the small bowel has been removed, which parts are still intact. Whenever you have loss of continuity of bowel because of the need for an ostomy and the loss of function, even though it's still present in the body, you lose the functional capacity of that distal bowel that's not being used. And so again, you have to include all of these things when you're thinking about how to manage a patient with surgical short bowel syndrome. The bowel has important immune function, digestive and absorptive and processing functions. And again, resection decreases the surface area, which leads directly to the functional capacity of that bowel and interferes with critical absorption and digestion. In this next few slides, I just wanted to put in a little about some of the feeding and nutritional issues and terms that you'll come across when discussing this population. The first is intestinal failure, which is most commonly defined as the need for parenteral nutrition for greater than 60 days. In the paper that's been submitted for publication, you can see that those with surgical short bowel had were most likely to have intestinal failure, being in an 84% of those with short bowel syndrome, 61% of those with NEC but no short bowel, and only 4% of those who were unaffected. Feeding is actually a topic that's very interesting to me, particularly in this population, because when a patient has surgical short bowel syndrome, for medical reasons, we often have to limit the capacity and the ability for these patients to take in enteral or oral feedings. But as a developmental specialist, I often think of this in terms of how it affects the maturation of what really is the first true developmental milestone, which is feeding. For feeding, you need sucking, swallowing, coordination of breathing. But because we have to limit this activity for medical reasons, we have to also potentially understand what the implications are for future development in other areas. In centers that have functional MRI readings, we've been able to gain some important information about activation of pathways. And we actually know that there's cross-activation between your feeding pathway and your language pathway. And so does the inability to have non-nutritive sucking or feeding in these early developmental phases affect the language delays that we see in these patients in the future. And also there's a high rate of feeding dysfunction in these patients, and how much of that is also associated with this inability or lack of nutritive feeding during these early developmental months. So again, this is the area that I think that there are lots of questions and issues about, but it potentially has longer term implications outside of just pure nutrition and nutritional intake in the NICU. And so what about brain injury and surgical short bowel syndrome? We often focus on the initial event, but we know that because of the inflammatory cascade that ensues because of this disease, that it's not just the time of the actual insult, but it goes on for days to weeks until these tissues ultimately repair. You have the initial oxidative stress and excitotoxicity, which leads to inflammation, apoptosis, and cell death, and ultimately repair. And so that, again, is part of the reason why it's so important to think about imaging and looking at outcomes in these patients beyond just the initial event. And this picture here, I think, is a nice example of all of the variables that can affect surgical short bowel syndrome and injury. And even though we often focus and talk about IVH, it's only one component. And this issue with inflammation, PVL, and white matter injury is probably equally, if not more important. And so you have the initial insult, but then you have to think about the interhemispheric connections associated with that insult, as well as the cross-hemispheric impact of these developmental pathways. And so I think with more advanced neuroimaging, we are going to learn more and more about brain injury in preemies in general, and also brain injury in our patients with surgical short bowel syndrome. And so a little bit about what is going on at Children's. I first became interested in this because I be in follow-up clinic and I see that little Johnny, who had a very difficult course with NEC and surgical short bowel, missed his clinic appointment that day, only to realize that he was in the hospital for a prolonged hospital stay. And then, you know, once you see this repeatedly, I realized that there was a pattern that because of their medical complexity and medical readmissions, it was very difficult to follow these patients in the context of a structured, typical preemie follow-up clinic. And so we decided to go to where the patients were instead of expecting them to come to us. And so we performed a convenient sample study of the 29 children who were being followed in the intestinal rehab clinic of Children's at that particular time. The ages and stages questionnaire was used because this was a screening pilot project just to get baseline information, to get some idea of what was going on with these patients. The mean age that this was administered was 26 months, and we found that a third of the patients had ages and stages questionnaire responses that were greater than 2 standard deviations below the mean in at least 2 domains. 17% had a diagnosis of CP, and most importantly, 76% had unmet needs and needed additional rehab referral services. And in this graphic here, you can see that even though the gray bars indicate the children who had previously received services, the blue bars indicated those who were currently receiving services, and the red bars were those who we indicated needed additional services based on our assessment. And you can see that many of these children were already receiving services, but many had unmet needs. And here, just quickly, I'll show you the distribution across the 5 domains measured with ages and stages. And you can see where the patients scored. Above means that they were doing fine and did not need referrals. In terms of those who were below, the most common reason was for communication and gross motor delay. But fine motor and problem-solving skills were also a problem in this population. And so from that, we decided to look at a larger population using data from the Neonatal Research Network and patients that we see for our routine preemie clinics who happen to have a diagnosis of surgical short bowel syndrome. The patients were divided into 3 groups: short bowel syndrome with NEC, those with NEC but no short bowel syndrome, and those who were unaffected. There's an 8-year study period that we looked at from 2008 to 2016, and each of the children had the Bailey scales of infant development administered, as well as having a standardized neurosensory examination. And here we can look just a little at the patient population. You can see that the gestational age was around 24 weeks with a birth weight of around 700 grams. About 10% were small for gestational age across each group. with a similar male to female distribution, slightly more females in unaffected patients. In terms of hospitalization, as I said before, intestinal failure and days on hyperol were longest in those with surgical short bowel syndrome. And hospital stay was also longer in that patient group, with the patients with surgical short bowel syndrome being discharged at an average of 49 weeks for adjusted age, those with NEC but no short bowel at 44 weeks, and those who were unaffected at 41 weeks. I put this graphic here, it's not related to the surgical short bowel patients, but just to give just a quick overview of interpreting these adjusted risk ratios. In the graphs that will follow, I only included the numerical values, but if you saw it in a graphical form, one represents equivalency, but anything to the right or anything greater than one suggests benefit, and anything less than one suggests no benefit. So here, this is looking at in-hospital morbidity, making comparison across our three groups. You can see that RDS was very common in all the patients as well as PDAs. As has been reported previously, late onset sepsis was more frequently encountered in our surgical short bowel syndrome patients, but also was very common in those with NEC but no short bowel. And here again, I think it highlights this issue of brain injury and severe IVH. IVH is really probably not the most important thing when it comes to looking at risk for neurodevelopmental outcome in these patients. And you can see here the differences between those with severe IVH and those with PVL, with the risk for PVL being significantly higher in these patients. If you can combine these two groups, it's even higher and statistically significant, in particular for those with who compared to those who were unaffected. And then we have BPD, which is something that's often discussed, again, common in all of our groups of patients, particularly those with surgical short bowel syndrome. And when we looked at the composite outcome of death or survival with neurodevelopmental impairment, as Susan said, these are two-year outcomes, and so limited in how much interpretation you can give to those. We included death as well as survival because really they're somewhat competing outcomes. You wouldn't want to exclude the children who died as not having an adverse outcome, which is why that they are combined. So we looked at them separately and combined. And for those with surgical short bowel syndrome, you can see that the percentages were higher in terms of death or survival with moderate to severe NDI. And then if we look at severe NDI, it's actually similar between those children with short bowel syndrome and those with NEC and no short bowel syndrome, but both were higher than those for unaffected children. And then the other portion of this is looking at NDI alone. And again, looking at those survivors who came for follow-up and had an assessment. Those with surgical short bowel syndrome had an increased risk compared to those without short bowel syndrome, as well as those who were unaffected, and the same for those with severe NDI. And I appreciated Lindsay's story when I look at this table, because as I often tell patients, when you talk about cerebral palsy and motor dysfunction, that really has to be looked at separately from your cognitive impairment. Patients can have motor impairment or motor discoordination, as she was describing, but their cognitive function is perfectly normal. So again, I encourage you to think about each of these areas in a particular silo, even though you have to combine them overall to look at the patient. in total. I did slip in the sensory outcomes here only to say that these are important outcomes in our patients, particularly looking for blindness and visual impairment in this group of patients. But really the majority of the slide, I wanted to focus on the motor outcomes. And you can see that for any grade of CP, more likely in those patients with surgical short bowel syndrome, in adjusted ratios, it was only significant compared to those who were unaffected. As a person who does developmental follow-up, each of the grades of severity is important to me because it has different implications on what that patient may need. Even though smaller numbers have mild cerebral palsy, that has important implication when it comes to school function, probably relates to their fine motor function. And then that's in contrast to those who have moderate or severe CP, who are going to have more functional impairment, and you think about the needs of those patients. And again, looking at the adjusted risk ratios, you can see the differences between those with and without short bowel syndrome and those who are unaffected. As I said earlier, the patients all had Bailey's performed. And if you look at the Bailey scores, the Bailey motor scores, a mean average on a Bailey motor is typically 100 with a standard deviation of 15. That's kind of considered the normal range. And so in all of these patients, the scores are lower than that mean of 100. But you can see across each of these groups, it's approximately a 7 to 10 point difference lower for patients who have either short bowel syndrome or NEC with no short bowel syndrome compared to those who are unaffected, all of which were statistically significant. And that was also consistent with their fine motor and gross motor subscale scores, all more common depending on grade of severe, the lower Bailey scores and grade of severity of CP. So on this slide, this is looking at cognitive and language outcomes. And as I stated earlier, you can see there's a little less of a spread in terms of the distribution of scores. Scores a little bit higher in this area. But again, you see the differences across the three groups. This is NEC with surgical short bowel syndrome, NEC without short bowel syndrome, and then your unaffected patients, the scores are higher. And you can see the statistical differences here. And then this is stratified just based on likelihood, based on the cut points of using 85 as moderate impairment, and then scores less than 70. And again, similarly, as it relates to language scores, significantly differences are noted here as well, with the lowest scores being in those patients with NEC and surgical short bowel syndrome. And again, the difference across the groups is approximately about 7 points. And the same exists in terms of their expressive and their receptive language scale scores. So in summary of this NRN data, we see that in most of our areas that surgical short bowel patients had the greatest risk for adverse neurodevelopmental outcome at 2 years of age. And in general, they have a tendency to have more risk in these more severe cut points. High risk of feeding dysfunction, suggesting that we need to monitor our growth carefully. And unfortunately, we have no data on the quality of life of these families and children for this particular study group. There are likely trends in improvement over time in numbers in terms of outcomes, but the numbers are small, therefore it's very difficult to interpret these data. And so for the N4 study, much of this is covered by Susan. We're performing a pilot study looking at these 4 components of NEC, nutrition, neuroimaging, and neurodevelopmental outcome at 12 and 24 months of age in patients with surgical bowel disease, NEC or SIP, using a near-term MRI with spectroscopy close to hospital discharge. And so just in summary, there are lowered Z-scores at discharge for all of our patients with NEC, whether they have short bowel syndrome or not. Over time, there is improvement by the time they arrive for that one-year follow-up visit, particularly in the somatic growth. However, the head circumference has remained small. And so Susan mentioned this already, but it's important to make sure we're monitoring that. MRI clearly is a more sensitive neuroimaging modality. In this pilot study, 67% of the patients had new findings noted on MRI compared to cranial ultrasounds. And in particular, cerebellar hemorrhage is something that is much easier to identify on an MRI. And we're finding about 47% of the patients have either cerebellar hemorrhage or cerebellar atrophy at the time of the study MRI. The spectroscopy data hasn't been incredibly helpful to date, but we continue to look at that. And almost half of the patients have evidence of white matter injury on MRI. So this study is still ongoing, and there's more data to come. And so finally, a little bit about the impact on the family. Traditionally, these patients received all of their care in the hospital. When I was a resident in Cincinnati, we had a special unit called the Convalescent Hospital for Children, where all of the chronically ventilated patients or instrumented patients had to remain in the hospital for their hospital stay. I'm sure that that unit doesn't exist anymore because over time, much of this care has transitioned from the hospital to the home environment. And part of that is because we now know that we can safely utilize tunneled central IV access safely at home for these patients, which allows for the use of home hyperalimentation use. There's been expanded use of nursing support in the home to help support families and children who are chronically instrumented, as well as the development of intestinal rehab teams around the world with specialized providers who are helping parents and families manage and handle these patients at home. And again, much of this has evolved from the assumption that we are improving quality of life for these patients. There's definitely improved survival, both in the NICU and as well as active management of these patients. There was a time period when a patient had such a small amount of remaining bowel length that they were considered, it was considered very unlikely that they would survive long enough for a multivisceral transplant or to be able to survive this disease process. And I think that that opinion has changed over time. Providers are using lipid minimization strategies to help protect the liver, their bowel lengthening procedures, and as I said before, these intestinal rehab clinics have been very important. And so in terms of the impact of the family, this is only one of a few. And even from our conversation today, I could add to this list. Some of the potential cons would be quality of life. We don't really know which variables are positive or negative. And so they really, quality of life, I put on both lists. Specialty care is needed to provide parents respite. You can't leave these children with the 12-year-old neighbor down the street because they have chronic instrumentation that requires special training. Parents have the burden of potential work loss, as well as increased out-of-pocket medical costs and medical bills. In terms of some of the cons, again, quality of life, we think is a definite potential impact because many of these children tend to thrive better in their natural environment. With the advent of the intestinal rehab teams, there are fewer inpatient hospitalizations, and we know that being at home is likely a more developmentally supportive environment for these parents and children, and less travel back and forth for medical appointments. In terms of longer term issues, as Lindsay pointed out, some of the issues related to socialization, going to family events, going to birthday parties, long-term need for G-tube feeds, dietary restrictions and dietary limitations, particularly as they go into the school age time period, medically fragile care, again, financial burden and this issue of lost work time. But then I think also a positive is that parents become engaged and develop a high degree of empowerment and involvement and the ability to be the greatest advocate for their child. So in summary, I would like to say that I think that there is a constant shift in the parent care paradigm requiring us really to make sure that we, in an active, real-time sense, keep track of the neurodevelopmental outcomes and family-centered outcomes in this patient population. Survival has definitely improved over time for a variety of reasons, including more active management of these patients. And I also would suggest incorporating developmental screening and developmental follow-up into your intestinal rehab clinics, because these patients are very difficult to follow in a traditional outpatient pre-me clinic. And it's important to identify and manage these unmet needs. But that definitely, there is variability in outcomes, but patients with surgical short bowel syndrome definitely are an at-risk population that deserve and require, as Lindsay said, not just saving their lives, but also taking care of them as they move forward in life and understanding the adverse outcomes that they need and receive. So I'll end by just acknowledging some of my collaborators, both locally and in the NICHD network, and would like to thank the NEC Society for this invitation to share this information and learn more about what's going on with all of our patients. So thank you very much.
And Ira, thank you so much. So much rich content, so thank you. We've got a lot of questions that have come in, and Ira, you can go ahead and pull your screen share down. We've got a lot of questions coming in, so I want to make sure we can turn it over to Ravi to help moderate our Q&A.
Thanks, Jonathan. And I'd like to start by thanking Lindsay really for such a powerful reminder of how much we don't know about NEC outcomes, and hopefully your and others' efforts to fill the gap, as well as for Susan, Ira. One of the questions I wanted, maybe if Lindsay, you want to touch on, and then we can get input from Ira and Susan, is who should follow NEC survivors after discharge in terms of the high-risk neonatology clinic, the pediatrician, the surgical team, as Ira mentioned, maybe the intestinal rehab team. I wonder if you could touch on that.
Well, personally, in my experience, I've had difficulty just finding somebody who even knows what NEC is or that long-term outcomes even exist. So I'm just starting at level 0 of just trying to get that acknowledgement. I definitely believe that maybe having a gastroenterologist, like having access to a gastroenterologist who can help me with my digestive issues would be very helpful. And not just, for a pediatrician, but also, having somebody that knows how to work with adults who have these long-term complications, because I'm noticing that the older I get, the less likely it will be that my physician is familiar with NEC and its long-term outcomes. And then also a neurologist as well would be really helpful, someone who's actually familiar with NEC as well.
Susan, Ira, any thoughts? Maybe we can start with Susan.
Yeah, well, I mean, obviously the most important voice here is Lindsay's, and I alluded to the fact that I think in a previous call together, she had said she still didn't really have a doctor or care team that she could rely on. And I think that is so important to hear, and it's such a powerful statement. I mean, on a broader scale, premature infants or children who are born premature who then become adolescents and adults, in general, there is a real challenge in those transitional points. It is even more acute, obviously, as Lindsay has described, for someone who has multiple aspects of the NEC experience. I really think that the work that's being done here in the NEC Society is going to be so critical, because right now that information is not that broadly known. As Ira mentioned, even the great work that Ira is doing, it still is not able to inform the entire continuum of life or the life course experience. And that transitional period and what kind of a team needs to be helping to care for a person who has experienced this. I think it's going to be so informed by the work that you're doing, Lindsay, and by the work that the NEC Society is doing. But as Ira said, and she can mention this, I think having really a multidisciplinary team as we are moving in the direction of, for many things that we care for in the NICU that then transition to the home and community, may be the way to go, with components, as you just mentioned, Lindsay, because it's not just, bowel issues, it's a myriad of potential challenges that you might encounter.
Thanks, Susan. And Ira, I know you mentioned kind of going to where the patients are and speaking about, following up. Could you speak a little bit about kind of where, these integrated teams and how to follow up?
Yes, I think one of the problems and issues is similar to what we have with following preemies in general. It really wasn't that long ago that neonatology as a specialty even existed. It was the 60s when we developed surfactant. So you think about how much has happened in just, a short 60 years. And so I think that the priorities people have changed over time, because at first they were just trying to get survival. And then even when you had survival, it was only for the healthier preemies. And over the years, that continues to improve and expand until you get to these really high specialty, small volume, but important groups, such as those with NEC and short bowel syndrome. And so this issue of care over the lifespan really, I think, is something that's relatively new and burgeoning in our area of specialty. And I think that being able to put together these teams of interested providers at all of those touch points is critical. The cardiac people are probably ahead of us, because they do have these teams where they're transitioning from pediatric care to adult care. And so I think that that's probably, outside of what Susan and I do, that's probably another big step. We need to see about establishing those kind of teams for our patients with NEC, so you don't have patients like Lindsay who can't find a GI doctor who doesn't understand the complications of NEC. And building multidisciplinary teams there, and identifying surgeons, GI specialists, even developmental people, because as she said, these issues don't go away, but interested parties at these different touch points. And I think that we need to do it at our early NICU follow-up. We need to do it at transition of care out of pediatric hospitals into the adult community as well.
Thanks, Sarah. I wonder if you could touch on, there's been a lot of interest in the NEC Society of the term or older gestational age babies who develop NEC. And we have a question here about, you could speak on the differences in neurodevelopmental outcome in older gestation babies, for example, greater than 32 weeks gestational age, and how NEC or surgical NEC might influence their longer term outcomes.
I would say that they still have similar risk. The 32-week gestation brain is very different than a 24-week brain. And so that goes back to that point that I was saying before. Kind of your foundational risk is based on your gestational age and follow-up, but then all of those other complications add to that risk. And so I think that in an overall sense, you tend to see that the larger, more mature babies that develop the disease are statistically, not necessarily each child is its own control, but statistically they are going to have a lower overall risk, but they definitely still need to be followed because NEC is a serious injury, causes inflammation to the brain, and can still have a lot of potential to cause brain injury and all of these other GI and related issues post-discharge.
I have a couple of questions, and maybe for Susan, we have some questions regarding babies who develop NEC or develop surgical NEC. They may have other higher illness severity, or other complications, such as, for example, a PDA. And so, when you're looking at some of the data on long-term outcomes related to NEC, how much of that sorting it out from the impact of NEC versus some of the effects on gestational age or human milk feeding and some of the other factors we know associated with NEC?
Yeah, I think that's a really great question. I think it's one that we struggle with when we look at the data, because we know from data in large cohorts that there are cumulative risks that may be linked together and may be separate morbidities that that impact outcomes. So, you may have recalled like the count of 3 different morbidities that has somewhat of a linear increase in neurodevelopmental adverse outcome, both at 2 and 5 years. That was in that's been published by Barbara Schmidt, and also the Victoria Infant Collaborative Group. So I think it is hard to sort out. Certainly, the factors that I very briefly laid out that are both associated with have been shown to be associated with adverse neurodevelopmental outcome in preterm infants in general may also be seen as complications in necrotizing enterocolitis. So, to what extent exactly what the proportion of sepsis that is associated with NEC may be related to adverse neurodevelopmental outcome due to inflammatory cascade issues, or exactly, the question of gestational age, I think, is also difficult because the cohorts are collected over this long period of time, and many of the cohorts are just, extremely preterm or very preterm, and those are the groups that are followed. So exactly how those all, I'm not trying to hedge, I'm just saying I'm not really sure that we know what is exactly the proportion of increase of these adverse outcomes. And then, of course, for both from Ira's discussion and from what I presented, there is definitely the mechanistic possibility that there is white matter abnormality as well as cerebral neuronal dysmaturation issues that are directly potentially associated with necrotizing enterocolitis. So it is a little bit hard to tease out, because if some of these things might be rolled into the event of necrotizing enterocolitis, and you wouldn't really want to take them out, as part of the whole picture of what a child may be dealing with. But I just really have to go back to Lindsay and reiterate the fact that these are individual children and their individual responses, and especially with an extraordinarily involved and committed family, as Lindsay had, and as Ira had mentioned also in her presentation, goes a long way to being able to help that child achieve the absolute best outcome that they can.
Thanks, Susan. Lindsay, I wanted to touch, maybe you mentioned a lot on quality of life and how that affected you over time. And I wonder if you could speak on when, as you were getting older, when you started to maybe realize how some of what you're experiencing was related to NEC. And then maybe to touch on Ira and Susan, at what ages do we think we can have, get an understanding of quality of life among kind of NEC survivors?
Thank you. So I did not know, my family did not know that NEC even had long-term complications. After I left the NICU, we thought I was done. And even though, as I mentioned before, some mornings when I was a little kid, how I'd have these little episodes of pain, and I'd always complain that my scar hurt, we never really thought that it was a big deal. We never really thought much about it until that one time when I was 16 and I had to go to the ER. And that's when it was brought to my attention that I actually did have long-term complications of NEC. And that really did throw us off because, as I said, we didn't even know that was possible. And so I think that's when it was really brought to my attention. And after that hospital visit, my life was really never the same again. I always struggled with constipation, with pain, and things just kind of started to get a little bit worse from there.
And I just wanted to mention we have a comment here about another family, about a son who's 7 who developed NEC, and again suffering from constipation and some of the similar things that may not always be measured in follow-up. But Susan, I wonder if you could talk a little bit about kind of assessing quality of life and how we can go about doing that, and maybe at what ages that we think we can get a sense of that.
Well, you know, I'll say I'm not an expert in this area, but Suroj Segal has done some amazing work with quality of life, as has Mike O'Shea in the Elgan group. And I think the most important thing about assessing quality of life is bringing in families and individuals who are affected, if they are able to participate, to kind of look at the different utilities indices, because the different kinds of questions that are asked are slightly different, and how they're compared to what is an expected quality of life is also different. So I think it's very valuable, as has been shown by Suroj, by work that's been done by Betty Vore and the late Maureen Hack, as well as Mike O'Shea and his group, that it's important to ask the individual who's affected, and it's usually, you know, in these preterm follow-up cohorts, it's former preterm, you know, child, adult, etc., as well as the family, because I think often you get a different impression of what the challenges are for the family. And also it's important, I think, and has been shown, to follow those cohorts, hopefully, which will happen more and more with NEC, along. So, you know, what's going on at 2 years is different from what's going on at 5 years, is different from what's going on at adolescence, or when you get to college, or as a later adult. So, and you can ask very different questions that get increasingly rich. And also the values of the family and the individual who's affected also shifts and changes. So I think those are all important to integrate in quality of life questions.
Yeah, and this conversation makes me think that we need to add quality of life surveys to all of our follow-up visits, and clearly that we need to be following these patients longer and in a more longitudinal fashion. And I think that early on, the quality of life measures would be those that would be geared towards the parent. But then as the children even approach school age, I've seen some as early as 7. So by 10, you can start to incorporate the child and get their impression. And oftentimes you're surprised, as you know, people have been, that the quality of life that the parents and the child report are actually better than what medical providers perceive. But I think, as Lindsay is saying, those types of surveys would help us get to some of these issues, because it actually pains me to think that you have had some of the difficulties that you've had, but I'm sure you're one of many, and that needs to be known and recognized so that something can be done about it.
And I wanted to touch on, we've talked a lot about, maybe to finish up, a lot about development outcomes, language and motor outcomes, but one of the questions we have here is about psychological impacts and how NEC and the experience of NEC has in terms of long-term psychological impacts, and how that can, and you heard really very compelling story from Lindsay, but how does that get integrated in terms of follow-up and in terms of psychological impacts, and how we can address those needs of NEC survivors?
You know, the most of the data that we have is on preterm survivors, not subdivided into those with NEC. I'm not sure as to whether the responses would be similar or different, and we really don't have that information. From the preemie data that we do have, preemie survivors absolutely are at higher risk for psychological and behavioral issues compared to term controls. That we do know.
Yeah, I agree with Ira. We don't really, again, I feel like we're a broken record here saying, boy, we don't have enough data about really what the truly long-term impacts are. But certainly from what Lindsay has said and what others have said who are survivors of NEC, the psychological impacts may also be connected to, and I think this would be important to integrate into long-term questionnaires, that psychological impact may be in part impacted by the fact that you don't feel that anyone is hearing what you say, or they may not be believing what I say, or I don't know if I'm being heard when I even see a doctor, which I think can be very impactful in a separate way from dealing with the medical and the mechanistic fallout from necrotizing enterocolitis. So I think that it's a very complex question that would be very, very valuable and could actually push public policy somewhat to recognize what the global need is to care for patients with this problem and their family, and what that group needs to look like, what that multidisciplinary group needs to look like.
Awesome. Well, thank you. Anything else, Ravi?
No, that was great. Thank you all for really
Awesome.
Participating.
Yeah, thank you to our remarkable speakers, especially Lindsay. We are truly honored and grateful to have each of you. And thank you to all of our participants for taking the time to join us and tune in. And we hope to see you again on November 18th. And just a friendly reminder to please vote now or before November 3rd. So thanks, everyone. We look forward to seeing you again.
Thank you.
Thank you.
Bye.
Thanks, everyone.